TAPP or TEP, which is better for laparoendoscopic inguinal hernia repair? A constant refrain at surgical discourses and a topic for endless debate, but unfortunately to which there is still no ready-made answer. Before proceeding further on this discussion as a preamble, there are a number of other laparoscopic options for groin hernia repair. In addition to time-tested and accepted TAPP and TP options, the list would be incomplete without the mention of the SILS option of both TAPP and TEP. And of course, the new kid on the block ETEP. But because the two most common methods are TEP and TAPP, so their comparison seems more appropriate. Having said that, for an ideal laparoendoscopic inguinal hernia repair, important considerations may be comparison of technical ease and reproducibility, and of course comparison of the assessment of usual end-point parameters including the serious complications, the recurrence rates, and the acute and chronic post-operative inguinal pain. But let us be clear about the favored option amongst the two. And the bottom line is that there is no ideal laparoscopic groin hernia repair. And there is no one size which fits all. For the simple reason, there are a number of variables which determine the outcome. Chief among them would be the surgeon's expertise. Number two, the patient factors, his comorbidities, and if any past abnormal surgeries have been done. The hernia factors, which include the extent of the hernia, whether it's a bubonocele, it's a funicular hernia, or it's a scrotal hernia. The type of hernia, basically meaning whether it's a primary hernia or it's a recurrent hernia after a past operation. And then, of course, the clinical scenario presentation, where the patient has come with an emergency inguinal hernia or in the elective scenario. While comparing the two options, the common take-home message which were and are still being repeatedly emphasized include that TEP is usually difficult and long learning phase is there. The peritoneal breach, if it occurs during surgery, then it's very difficult to complete the surgery, and the theoretical possibility of more vascular injuries. On the other hand, the downside with TAPP repair includes the theoretical possibility of more visceral injuries, the longer operative time, more port site hernias, and the more incidence of acute post-operative inguinal pain. A lot has been said about the long learning curve for TEP repair. But before that, what about the learning curve for laparoendoscopic groin hernia repair as a whole? The recommendations across the various hernia societies and over the years have been almost unanimous. So from 2009, we had the first recommendation, a European Hernia Society guidelines, which suggested between 50 to 100 procedures. 2011, the International Endohernia Society had similar guidelines saying that an expert hernia surgeon would be after he has done almost 30 to 100 procedures. And in 2018, the hernia surge guidelines suggested between 50 and 100 procedures before a surgeon becomes proficient in doing laparoscopic hernia repair. But a meta-analysis and meta-regression of almost 30 studies published in 2003 showed an improvement in the learning curve over the years. So they found that a significant decrease of 2.7% year on year number of cases for learning curve threshold to be achieved. And they found that the predicted number of cases needed to surmount the learning curve in 2020 were 32.5, which is down from 35.7 in the earlier phase of learning. So this was significantly different. So that means that over the years now, the learning curve is slightly decreasing, and that's probably the reason behind this is that a trainee surgeon is very well versed in doing laparoscopic surgery, especially cholecystectomies, appendectomies. So he knows how to handle these instruments, not as was about 20-25 years back when we had most of the surgeons in the learning phase in trying to handle these instruments. But what about the all-important consideration? Is there a difference in the learning curve between TAPP and TEP? When the analysis was performed independently for each operative approach, the fitted model demonstrated 34.4 cases for TEP or SILS TEP, that is less than 0.0, which is basically significant. P less than 0.01 and 22.7 cases for TAPP in 2020. So they did find a difference that the TAPP had a shorter learning curve than the TEP repair. Now, as far as the other comparative data is concerned, there are innumerable reports favoring either TAPP or TEP, but alluding to them would not be worthwhile. Instead, citing reviews and meta-analysis would be more suited for the occasion. And among the earliest was a prospective data study of 4,552 patients spread over 11 years from 1995 to 2006, which was published by the Swiss Association of Laparoscopic and Thoracoscopic Surgery, comparing TEP and TAPP for endoscopic unilateral inguinal hernia repair. And they found that the outcome that they compared was duration of operation, conversion rates, intraoperative, postoperative complications. And the conclusion favored a TAPP. And they found that with TEP, there was significantly higher number of postoperative complications associated with a longer operating time, higher conversion rate, and therefore on a population-based level, they concluded that TAPP technique appears to be superior to the TEP repair in patients of unilateral inguinal hernia repair. Another study which came out in 2016 was for recurrent inguinal hernia. This also was a prospective study, had 1309 patients, and this was again comparison of TEP versus TAPP, but this time it was for recurrent inguinal hernias. And they found that in TEP, the intraoperative complication was significantly higher. The TEP technique was shared with longer operating times, but a shorter postoperative length of hospital stay. So basically meaning that here also they showed that TAP was better, but the absolute outcome differences were small, and thus on a population-based level, they said that the both techniques appears to be safe and effective for patients undergoing endoscopic repair for unilateral recurrent inguinal hernia. Then came the hernia surge guidelines for 2018, and they had a strongly upgraded recommendation, and in which they said the choice between TAPP and TEP is not based on the outcomes. It is basically because they both have comparable outcomes. So it is basically dependent on the choice of technique by the surgeon, the education and experience. That basically means it has to be a patient's interest and the surgeon's skill and the experience of the surgeon, which should ultimately determine what procedure to be offered to a patient, whether it's a TAPP or TEP. But they did have certain statements which had both pros and cons for each of the procedures. And in TEP, they found that there is a trend for vascular injuries, although very, very rare. They also had a higher conversion rate during surgery because of new peritoneum, and the TEP has a longer learning curve than TAPP. But as I said earlier, they had EQ vocal recommendation that both TAPP and TEP have comparable outcomes. So it would ultimately depend upon the surgeon and the patient's choice. Now, they also went on further to say that there are certain instances or certain scenarios where TAPP may probably be preferred. So in patients who have a large scrotal hernia, they recommended either open or TAPP. TEP was never mentioned here. So either patient is subjected to an open hernia repair, or he can be offered a TAPP repair. Similarly, for irreducible inguinal enterocele, the group recommended individualization for a choice between open or TAPP. Prior infraumbilical surgeries or interventions, like for example, midline, transverse, lower abdominal wall incision, prior pelvic surgery or prior pelvic radiation, patients requiring simultaneous diagnostic laparoscopy, and patients and female patients. So in all these patients, probably TAPP may be a better option as compared to a TEP. 2021 was another sequential a trial with sequential analysis of randomized controlled trials, which was 15 RCTs covering 1359 patients, comparing TEP and TAPP again in inguinal hernia, and they were looking at the recurrence and chronic pain, and they found that both the procedures are comparable as far as recurrence and chronic pain is concerned, and they went further to say that similar trials or meta-analysis seem unlikely to show diverse results and they should be discouraged. Then came the upgraded hernia surge 2023. This was an upgradation from the 2018 guidelines, and for unilateral and bilateral elective groin hernia repair, they had no change in the recommendation. But there was a change as far as the emergency inguinal hernia management was concerned in these upgraded guidelines for 2023. And the recommendation number one was that when approaching an acutely irreducible groin hernia, it is suggested to use a diagnostic laparoscopy if the expertise and resources are available and the patient's condition allow it. The second recommendation was an extension of the first recommendation, that if you're doing a diagnostic laparoscopy and if you feel that the patient can be selected to do surgery, then a laparoscopic hernia repair can be attempted if expertise is available. And as an extension, because if you're doing a diagnostic laparoscopy, so it is preferable to do a TAPP rather than going in approaching from the intrapetal, approaching a prepetal space and then going ahead and doing a TAPP. So that's an obvious corollary from the recommendation number one. And the third recommendation, which probably helped in the recommendation for carrying out a TAPP repair or a laparoscopic inguinal hernia repair even in emergency condition, was that in patients with intestinal strangulation and or concurrent bowel dissection, that basically means CDC type 2 scenario, a mesh repair could be used with a trend in favor of a macroporous mesh. Further substantiated by the surgery up to date April 2024, this was the mesh update, and they said that for groin hernia, a clean contaminated wound, CDC surgical wound class 2, like for example strangulation and or concomitant bowel dissection, a synthetic monofilament Rajpur mesh could be used for repairing the hernia. But not so if the wound was class 3. That means there was frank contamination or spillage. In these cases, do not use a mesh. So up to CDC type 2 wounds, you can go ahead and do a mesh repair, even in emergency inguinal hernia repairs. Then came the Cochrane recommendation as comparing again TAP and TEP. This was the July 24, and they said that there will be little or no difference between the TAPP and TEP in terms of what? Serious complications, chronic pain and hernia recurrence. So both are equal in these outcomes. But if the TEP technique is used, they said that there are chances that there is a higher risk of having to change to another surgical method during the procedure, which basically spells into technical difficulty remains. Future studies should investigate quality of life of patient undergoing TAPP or TEP for groin hernia repair. So these were the Cochrane 2024 recommendations. Then came a very large meta-analysis of 2024, and this was an analysis which had almost 18,000 patients in one study and 32,000 patients in one study spread across 2005-2021, and they compared all possible outcomes, like for example operative time, post-operative pain, hospital stay, time to return to work, post-operative complications and recurrences. So this was meta-analysis, and this basically spelled out that when we compare TAPP and TEP, there was no significant difference between the two techniques in inguinal hernia repair. Only one study of Hung et al. In 2020, they said that TEP may have a higher seroma rate and a lower scrotal edema. But otherwise, no significant difference were found between the two techniques in this large meta-analysis, which covered almost more than 50,000 patients taken together. This study also recommended that if the patient has a recurrent inguinal hernia, patient has a bilateral inguinal hernia or a unilateral inguinal hernia and is fit for general anesthesia, then he should be offered as the first choice laparoendoscopic repair as the first choice. And if this patient, if the BMI is more than 30, inguinal scrotal hernia is there, previous pelvic surgery or radiation history is there, and there is a scar of previous open abdominal surgery, then he is probably better served by being offered a TAPP as compared to patients who do not have these variables, and they could be offered TEP. That means a BMI less than 30, a direct femoral or obturator hernia, not inguinal scrotal, remember, no previous pelvic surgery or radiation, no previous abdominal surgery, open surgery, they can be offered a TEP repair. So in favor of TAP, apart from the fact that hernia surge 2018, which has suggested, we already specified large scrotal hernia, irreducible inguinal enterocele, prior inflammatory surgeries, patient requiring simultaneous diagnostic laparoscopy, and female patients, probably TAPP is again a better option in patients in whom you require managing a large pseudosac. It is easier to do that if you have a TAPP. Short puboumbilical length, again TP becomes very cramped. Recurrent, so TAPP would be preferred. Recurrent hernia, especially with preperitoneal mesh placed earlier, in these cases, again probably a TAPP repair would be a better option. What about the new baby on the block in groin hernias? And that is the ETP. Now, a comparative evaluation of extended total extraperitoneal repair versus standard total extraperitoneal repair, which are basically TAPP and TP and of course ETP. Now, this was our study. Until that time, there were no such study in these patients. In the study, in the publication, there was no publication of a similar study. This is the only study you can find in the literature at that time, and published in 2023. And all the three laparoscopic hernia approaches had similar outcomes. That's what we found. The ETP cannot be advocated as a substitute for TAPP and TEP. The choice of procedure should be the surgeon's choice. However, a TP does combine the advantage of both TAPP in the form of large working space and of TEP by being totally extraperitoneal. ETP is also easier to learn and teach. So that was our conclusion, and this was the only study to date which compares TAPP, TEP and ETP. Ever wondered how many surgeons opt for laparoscopic hernia repair for groin hernia? We have been discussing TAPP and TEP, but out of all hernia surgeons, or for surgeons in general, how many of them do opt for a laparoscopic approach? Now, despite all these recommendations, international guidelines, the utilization remains very variable. Very few countries have more than 50% surgeons opting for a laparoscopic repair as a first choice in groin hernia. So Germany, New Zealand have figures of more than 60%, Denmark more than 50%. But strangely, USA has almost 38% of surgeons only who would opt for laparoscopic repair, who are carrying out laparoscopic repair. Even less in England, down to 23%. And in Spain and South Europe, which means Italy, Spain and Greece, it is very, very meager of 5.7% and 10%. So that means the surgeons who are doing laparoscopic repair are at a premium. They are almost very less surgeons are carrying out a laparoscopic repair in countries of Europe, and slightly more US and England, and the highest figure is in New Zealand and Denmark. That this was a study which was published, and the difference is not only because of lack of expertise and infrastructure. There are other factors which have been taken into account in these studies, which are responsible for carrying out open hernia in favor of a laparoscopic repair for inguinal hernia. And as an extension, have you wondered if you're doing a laparoscopic repair, or all surgeons doing laparoscopic repair in inguinal hernia, how many of them are opting for TAPP and how many for TEP? And this was study in 2015 which said that the TAP procedure is still the most commonly performed laparoscopic inguinal hernia repair. So worldwide, the preference is for TAPP as compared to TEP. This was the conclusion of the study of 2015. And this was a survey of general surgeons regarding laparoscopic inguinal hernia repair, the practice patterns, barriers, and educational need. Now, what is the final word? TAPP or TP? So the final word is equivocal. Based on published results, the hernia surgeon should master both TAPP and TP techniques and also ETP if possible. Choice of operation to be recommended based on number one, personal expertise, hernia, patient characteristics, and locally available technology. So we are back to square one, that there is no hard and fast recommendation in favor of TEP or versus TAPP. It would ultimately depend upon a host of variables, and each patient to be treated as depending on these variables which procedure is going to fit him the most, if at all he is indicated to be having a laparoscopic endoscopic repair. So which would you prefer, TEP or TAPP? That will depend upon the characteristics that we just now enumerated. Thank you for your time, and you can go to my website on YouTube Prime, Rajiv Sinha GHS, and please do not forget to subscribe. And you can see more than about now 106 instructive videos on my website. Thank you very much.